Welcome to the South Carolina Medical Association's PCMH webinar series. This is the webinar that focuses on Standard 5 of NCQA's PCMH standards and guidelines, which addresses care coordination and care transitions. I'm Scott Holtstrand, the PCMH Project Director at the South Carolina Medical Association, and Claudia Cartledge, I want to thank her, who's a PCMH consultant on the project, for her assistance in preparing this presentation. What we hope to learn from this presentation is a comprehensive understanding of NCQA requirements for Standard 5. For those of you who are new to this webinar series, we've already done a number of presentations, an introductory presentation and then specific presentation on Standards 1, 2, 3, and 4. And then next month in October, we'll be completing this series with a presentation on Standard 6. But today the focus is going to be on Standard 5. And we also want to talk about how to really develop and understand care coordination approaches as far as they relate to the NCQA standards so that you can achieve practice efficiencies and provide better care to your patients, particularly when they're not with you, because Standard 5 is really a lot about what happens when your patients need care or need certain services, but it is not when they're in your office. And so we'll talk more about that along the way. But before we get into the specifics of NCQA's Standard 5, I want to talk about 3 different projects that were highlighted in various journals that address care coordination and its significance. The first one is from the Journal of General Internal Medicine. And what this study looked at is several thousand adults that had a primary care physician and who had visited specialists in the past year. And what they wanted to look at was how informed the primary care physician was and what kind of level of conversation occurred between the primary care physician and the patient when the primary care physician was the one that referred the patient to a specialist versus when the physician did not refer, when the patient self-referred or maybe was referred from another source. And what this study found was when a primary care physician refers a patient themselves to a specialist versus some other type of referral, the primary care physician is much more likely to be informed and up to date about care that the patient is receiving from the specialist, and also much more likely to discuss with the patient the care that the patient received during the specialist visit. And so what this study shows, among other things, is the importance of the primary care physician being on top of specialist referrals, really being the quarterback and source for specialist referrals. And part of the PCMH standards that we'll be talking about addresses this issue. Another study, which happened in the VA setting, took a look at alerts that providers were receiving when images came back with an abnormal result. And what this study looked at was how often the electronic medical record resources were being utilized to view the abnormal results and how aware were the providers that abnormal results had come through. And if you look at these results here in the middle of the page, you can see that there were over 100,000 studies. And of those studies, about 1% of them, around 1,200, generated alerts that should have notified a provider that there was an abnormal result that needed additional follow-up. And what you can see is that almost a little over 18% of those alerts were not acknowledged. Y'all may have heard of alert fatigue, where you get so many alerts in a medical record that you start ignoring alerts, or you just have so much going on that you pass right over things that are important. And so another thing that the PCMH standards help us to think through is how can we develop processes that ensure that important things like abnormal image results that require follow-up do not get missed. And then finally, a third study looked at 4 different family medicine offices. It was more of a qualitative study of test results and whether or not patients were receiving results of the tests that were ordered from the primary care physician, and then how that was documented in the charts of the patients. And what the study revealed is that many times patients do actually receive the results of studies. The percentage is actually pretty high. 87 to 100% of patients acknowledge that they received test results from their clinicians. But as far as documentation of that notification, what the clinical response was, the follow-up, things that are very important to do when results are given to patients, the percentages were a lot less on those areas. And what this study found really is that there was not a uniform process for communicating results to patients and then recording those results. Of course, if we're communicating results to patients, we want to know what we've communicated to them, not only from a liability perspective, but just from a patient care quality and safety perspective. So what the study revealed is a need for physician practices to think through the process that they have set out in terms of providing test results to their patients. And again, just like these other two studies, the NCQA standards help us think through these issues. And that's one reason why the standards, Standard 5 can be such a difficult standard, because a lot of times physician practices do a lot of these things, but they've never taken the time to think through, maybe are we doing this the best way? Is our process the best way to communicate to patients and to make sure that we don't miss important things that are happening to their patients when they're not with us? And so what Standard 5 really forces us to do is take that step back and take a close look at how do we handle imaging and lab results? How do we handle specialist referrals? What do we do when patients present to the emergency department or are admitted to the hospital? And so what we're going to do now is a very brief overview of the three elements that are in Standard 5. And then following this, we're going to take a deeper dive into each standard and look at each element, along with several examples, either from NCQA or with practices that we've worked with, of how we're going to prove this to NCQA. Because as you all know already, it's one thing to say that we do these things, it's another thing to put what you do on paper in a way that NCQA can understand and approve. So we'll talk about that along the way. But just as a very brief overview, there are three elements in Standard 5. Standard 5 is worth a lot of points. It's worth 18 points, so it's almost 1/5 of the whole PCMH project. And there's three elements. Element A is all about how do you track tests that you order for your patients, whether they be labs or imaging. And we'll be talking more about that later, but just generally speaking, this is all about labs and imaging that you order for your patients and how well you track getting the results back and then providing those results to your patients. The second element, element B, is about how you track and provide referrals to specialists. And so if element A is all about labs and imaging, element B is all about specialist referrals and how you handle specialists and the information that you're providing back and forth and getting reports back from them. We'll talk in more detail about this a little bit later. And then the third element in Standard 5 is element C, which is about care transitions out of the hospital and emergency departments. And so this this element is all about how are you aware of what your patients, what kind of care they're receiving as they're admitted to the hospital or when they present to the emergency department? What is your communication like with the hospital during care transitions and while they're in the hospital receiving the care? And so we'll again be going a little bit deeper into that later on in the presentation. First of all, though, let's go back to element A, which is about test tracking and follow-up. And if you look at these first two factors, you'll see that they're critical factors. And so you can't get any points in element A unless you do these two things. So it's very important for you to consider whether or not this is something that you're doing, and if you're not doing it, how you would implement this in your practice. And what this is they want you to track your labs and imaging tests as you order them. And when they say track, what they mean is they want you to follow these orders until the results are available. And then if the results have not come back within a time that you have determined to be a timely response to your lab or imaging, then NCQA wants you to be able to flag and follow up on overdue labs and imaging results. So for example, you have ordered some sort of blood work for your patient. They would want some mechanism in place for your office to see whether or not that blood work has gotten back in time. And if it hasn't, to be able to follow up either with the patient or with the lab to get the results back that you need. These are both very critical as a foundation for anything that you'll be doing in terms of tracking labs and imaging. So NCQA, for that reason, has required practices to do this to get any points out of that element. So here are just an example. The thing about Standard 5 is that every practice does it a little bit differently. You might do it in your EMR. You might do it manually in a log that you keep. There's lots of ways that you can track labs and imaging and specialist referrals and other things. So the examples that we'll give may not fit directly with what you do, but we'll be able to help you with that as part of our PCMH consulting. But if you look at this, this is actually an example from NCQA. This practice had each lab, when they were ordered, they had a red overdue flag come up if it was overdue. They described what kind of order it was, and had the ability to track labs that way. And so this is one way you can do this. I'm pretty sure in this case it was an EMR that did it for them, but you can do it in a host of different ways. And then we're going to look at the factors 3 through 6 of element A. And what they want you to do in factors 3 and 4 is they want you to flag when abnormal lab and imaging results come in and then bring them to the attention of your clinician. It's very important if you get abnormal images or labs to let your clinician know so that the clinician can respond with further follow-up or further labs or imaging testing if required. And so again, you need to have a process in place for doing this. And most folks, if you have an EMR, this is something that's done pretty automatically. And if it's not, we can help you think through how to flag this. And then number 5 is notifying patients and families of normal and abnormal lab and test results. In many practices that we work with, the practices wait for patients to call to request what the results are. Part of being a patient-centered medical home is being more proactive and reaching out to patients and families when you get the results in, so they don't have to wait till the next visit, and so that they can get notified of the care right away. And then number 6 is only for pediatric practices. Adults are not required to do this, but if you have a pediatric practice, they want you to follow up with the hospital or with DHECs in some cases about newborn hearing screenings and blood spot screenings. And most peds practices we've worked with have a process in place for this, so this is usually not too much of a challenge. And so if you look at this example of an EMR, it had various flags and warnings for the physicians. It was red if it was really bad, yellow if it was something that was not to the level of critical but still needed to be, the physician still needed to be aware of it. And so it's likely your EMR has a similar way to notify your clinicians of abnormal labs. This is just one example. This is another example of a lab and imaging tracking. This is a lab tracking EMR system. And again, this will show the abnormal lab results. And it also keeps track, if you look in the middle where it says phone outgoing call, this actually can track the notification that is given to the patients. And so in some cases, you'll be able to use a telephone encounter to show how you've contacted your patients. If you see here, this is an example of a letter that's used to notify patients of a normal result. And a lot of times there will be a different way that you notify patients of abnormal or normal results. And really it gets down to what your practice does and how you want to achieve these things. The final 4 factors in element A really address meaningful use issues. These are meaningful use, or most of these are meaningful use data points. So you'll be able to use meaningful use reports, for example, for number 7, 8, and then number 10, if you selected that as a menu item, you'd be able to use that. So this is really just more percentages of lab orders that are electronically ordered or images that are electronically recorded in your patient record, how you're incorporating those lab results in your record, and then whether or not you can access scans and tests with images that are accessible electronically. In many cases, practices have been scanning in images and recording results electronically for quite a while, so this is typically not too difficult for practices. And again, you can use any meaningful use reports that you have to prove that you are compliant with these various factors. Let's talk a little bit more now about element B. So if element A is all about labs and imaging and how you track those, Element B is all about specialist referrals and how you track those. But it's more than that. And what NCQA has done, particularly with these first 4 factors, is they've gotten a little bit ahead of the curve, particularly as it relates to care provided in South Carolina. There are parts in the country that are doing these things. We have found as we've gone out into South Carolina that most practices are not doing these things. But you are still able to pass this element B without doing these if you're not doing this. Element B is a must-pass element, so you do need to pay very close attention to this element. But if you look at number 1, it talks about considering performance information on your specialist. In most cases, you do not have this kind of information available to you. And so this is a difficult one to pass right now. If for some reason you are using some kind of information on specialists that you're referring to, you'd be able to pass this one. This will become more and more available as time goes on, but right now, particularly in South Carolina, this is not readily available. Number 2 is about maintaining agreements with specialists. So this may be a neurologist or an endocrinologist that you refer a lot of patients to, or a psychiatrist or someone else. And it's a either formal or informal way that you have established what each of you are going to do in terms of providing care for that patient. And again, in many cases, this may be done verbally, and we might be able to explain some of these things to NCQA if you're doing this in a verbal context. Otherwise, most providers that we have met with are not putting this in writing at this point. Though as we continue to evolve as a healthcare system, the way that you interact with specialists is going to become more and more important, particularly as you seek to manage your chronic care and high-risk patients. Then numbers 3 and 4 are about behavioral health. 3 about maintaining agreements with behavioral health providers, and 4 about integrating behavioral health on site. Again, this is something a lot of folks are not doing right now. There are some we're working with that have integrated behavioral health on site. Most have not. And then in terms of maintaining agreements with behavioral health care providers, this is something that, again, is not very prevalent in South Carolina right now. If this is something that you do, we can get credit for it. And if not, it may be something you want to consider, particularly as behavioral health is becoming so significant in terms of managing your patient populations. But we can talk about that when the time comes. This is just an example that NCQA gives of an agreement with, this is between a primary care physician and a cardiologist. And if you look at it briefly, it says, here's what you do in terms of when there's a referral, here's what our expectations are of what the patient should be able to expect for care coordination, here's what we need to do with labs, with who's going to monitor a patient's care plan, that kind of stuff. So if this is something that you're interested in, we can help you think through how you would do this with specialists. But again, you can pass this element without doing these things. Numbers 5, 6, and 7 are things that you are more likely to be doing. Number 5 is simply when you provide a specialist with a referral, or when you refer a patient to a specialist, are you providing the reason for the referral so that the specialist can know why you're sending the patient to them, in addition to how quickly you need to see the patient, whether it's urgent or whether it can wait. This is very important information that the specialist needs to have, and in most cases that we've seen, this is information you are providing to your specialist. Number 6 is giving pertinent demographic and clinical data, test results, and current care plan to the specialist. In most cases, practices are doing this. You're sending this kind of information already to the specialist. If you're not, we can help you think through how to do this. And then number 7 is actually a meaningful use about summary of care transitions. Again, you're either meeting that 50% requirement or you're not. If you are, we can use your meaningful use report to prove that you're providing that electronic summary of care record information to specialists. This is just an example of one practice we work with where we use a meaningful use report. And if you look there, the example says 5B7 and 5C7. 5C7, which we haven't talked about yet, you can use the same meaningful use report for that you also use for 5B7. And then factors 8 through 10 are really key because factor 8 is a critical factor. You really got to do factor 8 in order to pass. And so factor 8 is similar to the tracking labs and imaging, except this time you're tracking your specialist referrals. And in this case, what NCQA wants you to do is when you make a referral to a specialist, they want you to track whether or not you're getting that report back. And if you haven't gotten that report back in a time that you deem to be a timely response from the specialist, then you're going to follow up with the specialist and then track that follow-up to make sure you're getting the reports back. We'll show you an example of that in a second. And then if you do any type of co-management of a patient with a specialist, NCQA wants you to document evidence of that in their charts. And this is something that a lot of practices are not doing right now. If you are, you'll have to have 3 examples of that in your chart. And then NCQA wants you, and this kind of coincides with the one of the quality improvement studies we talked about at the beginning of this presentation. NCQA wants you to ask patients about whether or not they made their own self-referrals to other specialists, and if they have, to reach out to those specialists and get the reports back. Again, this is all part of providing better quality care and safer care to your patients. We, of course, would want to know if a patient has received care from a specialist, what that specialist, any diagnoses or orders, or any other types of plans that came out of those visits. It'd be helpful for us as the quarterback for the patient's care to know those things. This is an example of a manual log that a practice we work with kept to track the specialist referrals. And this basically does exactly what NCQA asked for. It tracks each referral that is made, when the referral was made, when the expected appointment is, and then, when the appointment was made, and then the date that the report is anticipated back from the specialist. And then it has 2 more columns for when the report actually comes back. And if the report is late, it has a column for follow-up to make sure that you're following up and not missing reports coming back from the specialist. This is another example similar to the first one, other than it was a report done in Excel rather than manually or in handwriting. It's basically the same thing. It's got all the referrals, who they've been made to, the date that you expected to get the report back, which again, you can set your own standards on that. And then when you actually got the report back and when you haven't gotten it back within the time that you expected, it's got room for follow-up and the date of the follow-up that you made. This is another practice we work with that asks patients about self-referrals on their intake. You can do this using a tablet, or you can obviously do it just in your intake form that you're using for your patients. Just ask your patients, have you been to a specialist since your last visit? And if the patient says yes, you get that information. And this practice kept a log. And this is not going to be very often. As you know, most patients rely on you to provide referrals to specialists. But if for some reason they do see specialists without you referring them, then this is a good way to keep track of that and reach out to specialists to get their reports. Let's now talk about element C, and this one probably has the most variation and variability, particularly if you are not a hospital-employed practice. If you're integrated with a hospital system, this tends to be a little bit easier to do. Otherwise, you've got to have a good relationship with the hospital in order to get this kind of information. Or if you still round as a practice rather than use the hospitalist, this is something that you can still do even if you're not an employed practice. And what NCQA wants you to do in Standard 5 Element C is make sure that when your patients are in the hospital, whether it be admitted into the inpatient facility or presenting to the emergency department, that you are aware of this and providing a needed care for your patients when they're there. And so what they want you to do in number 1 is identify patients who are admitted or who go to the ED. Many practices get a daily list sent from the hospital, or they can access the hospital's system to look to see if any of your patients have presented to the hospital. And that's a good way to do it. Number 2 is about sharing clinical information with hospitals and emergency departments. And many times when you're admitting a patient to the hospital, you send them appropriate information. Sometimes hospitals have access to your medical records. There are other ways, other arrangements that you can make for sharing this information. And then number 3 is making sure that you get discharge summaries. Some hospitals send it automatically. Some hospitals will allow you to log on to their system and take a look yourself. Others will alert you when patients are discharged and you need to reach out to get the discharge summary. But again, we want to know what happens when our patients are there, and so getting these discharge summaries is important. So this is an example of a practice that received information from hospitals when their patients presented to the hospital. So they would get this updated list that was updated, I think it was on a daily basis. Another one is a follow-up log that practice kept when a patient was admitted to the ED. The practice made sure that they kept track of following up with the patient and whether or not a visit needed to be scheduled. And then this is an example of a practice we work with that would scan the discharge summary. I think the hospital faxed the discharge summaries to the practice, and then the practice would scan the discharge summary into the patient's chart. And this is how we proved NCQA that we were actually following the discharge summaries. And then factors 4 and 5 have to do with how are we contacting patients for follow-up care. We've already shown an example of that. Again, you define what your appropriate period is for follow-up, and then you show NCQA how you're contacting patients after they're discharged from the hospital or after an emergency department visit. They also want to see how you exchange patient information with the hospital when the patient's hospitalized. Some of that may be through rounding, others of it may be through fax or through EMR connections. Every practice is different, and so we'll help you think through how you'll prove this to NCQA. Number 6 is about obtaining proper consent for release of information when you're referring to other community partners in healthcare. And so this might be juvenile justice facility, foster care, adult protective services, jails, others. You need to have a process in place so that if they're requesting information, you can provide information that they need if they need to provide care to those patients. And then number 7, what we've already talked about, this is a meaningful use, about summary of care transitions. And if you've done 5B7, you can also do 5C7. You can use the same meaningful use report for that. Well, I know this has been a very brief overview, and part of that's intentional because every practice is going to be a little bit different. It's hard to go too much into specifics on this because how you handle your labs, imaging, specialists, hospital, ED, and inpatient admissions is going to be just a little bit different for everybody. And so what we're prepared to do as your PCMH consultants is work with you to either show NCQA what you're already doing, if what you're doing is compliant with NCQA standards, or if you are not compliant with NCQA standards. We've seen lots of different ways to do this, and so we can help think through creative and efficient ways for you to do these things. But this is really important because more and more your quality reporting that you're going to be measured on, and even the way that you're paid, is going to hinge on how well you manage care transitions, how well you keep track of what's going on with your patients when things are happening outside of the 4 walls of your office. And so it's important at this stage in the evolution of healthcare for you to get this under control and really have adequate processes in place to handle all the things that are going on when the patients aren't with you. And the faster you are in positioning yourself to do this, the better off you'll be in terms of complying with new expectations that payers and others will have, and also providing the quality and safe care that's going to be expected and is already expected for your patients. So at this point, we're going to conclude this presentation. And the only thing I'll say at this point is we are more than happy to address any questions or concerns you have about this. This is a difficult one to prove to NCQA because it requires a lot of processes and a lot of screenshots and other things that show how your processes actually are implemented. And that's one thing that we'll help you do is make sure that you get the documentation that you need to prove to NCQA that you're doing this. And we hope that along the way that this won't just be busy work and documentation, but what this will be is a time for you to take a step back, take a look at how you actually are managing the care that your patients are receiving when they're not with you, and then take steps to maybe improving on how you're tracking and following your patients and making sure that your patients are receiving all the care that they need particularly as they transition across different parts of the healthcare system. Well, we really appreciate you listening to this presentation. If you have any questions, please feel free to email me at scotth@scmedical.org. And we look forward to October's presentation, which will be on quality improvement, a very important piece of NCQA's patient-centered medical home. And until next time, we hope that you're well, and please reach out to us with any questions. Thank you.